Spotlight. I'll ask the four speakers to come up to the platform, please.
Yeah, why don't you ask your question whilst they're sorting themselves out?
So just a comment on the recent international Y90 study, which just came out, and that supports very much what you're saying. We found within a group that the progression-free or the overall survival was best in our patients who had durable diarrhea cessation. So those that after the first treatment stopped their diarrhea had an overall better response by twice. My question, though, relates to observations of the several hundred we've sent over to Europe for treatment of Y90, and that is that I'm most interested in that 9 to 12 to 18% progressive group. And the impression I have is, and I've had PET scans performed right at the end of the second treatment, and it's obvious, and it's not obvious with the Octria scan which ones will progress, but it is obvious after treatment those that maintain higher SUVs and respond to a more aggressive therapy right when they get back. My question is, have you looked at, any of your group looked at that progressive group to find out in the matriculation which ones may or may not respond to the therapies, either yttrium or lutetium?
Well, with the yttrium group, we thought originally it would be those who were the poorly differentiated tumours that had the poorer response, but it was actually, the numbers are quite small, but it wasn't significantly obvious. With our MRBG group, from the one that we published this month, that is true. The patients who didn't respond as well to MRBG did have more poorly differentiated tumours. But with the yttrium, certainly in the first 100 or so patients, we didn't find that, though we thought that would be the case. Remember, most of these poorly differentiated patients have already failed quite significant chemotherapy, streptozin, cisplatin, 5-FU. So they've already had quite heavy, significant treatment. So we thought, and clinically they were in a poorer condition when they came into the treatment program. So we thought that the chance that they would probably die quicker. But certainly with our small group, that's not the case. But I don't know if Eric's noticed anything from the lutetium group.
Well, I can only answer this question, and I would like to refer to our... Where is Tom? Oh, there, sorry. To our article, the Krakeboom article of 2 years ago, where he is showing the factors predicting disease-specific survival. So there he is showing which factors are indeed predicting a shorter overall survival. And there are several. I can mention the presence of bony lesions. Simple. The Karnofsky performance index at the start of the treatment being lower than 70, those patients will respond less favorably. Liver involvement. That are all kinds of criteria which you can use to make a distinction between the patients who will respond better or less good. So we have no PET scanning, so I cannot answer your SUF questions, etc. But that is practical, I would say, practical medicine to make this distinction.
That's a bit like learned hopelessness when they come over to be treated then. I mean, I'm asking about, I can't imagine, are all of those patients that you would predict to have a poor response indeed go on to a poor response, or do some of them respond?
Yes, some actually respond very well. And I think that's the thing, is that though these are trends which suggest poor response, the reason we continue to treat is maybe anecdotal, but we do have patients who have poorly differentiated tumour with liver and bone mets who actually respond very well. And particularly, as Eric's saying, the combination studies of an intra-arterial treatment for the extensive liver metastasis followed by intravenous. We've rescued patients who I would describe as a melon on a stick, have a large liver and ascites, cachexia elsewhere, with a fairly poor Karnofsky score, and the chances are low. But we have, half of these patients have survived and gone on and survived well. So the point is, as I think you put up your slide about, hope always, I think the thing is that it is with a fair and discussion with the patient about likely outcomes, and that unfortunately the chances are not as great as somebody who has better prognostic outcomes. If the patient's willing to try, we're willing to try, and I think that all of us have experience of patients that we thought possibly wouldn't do well who have done well.
Except take the question from the other microphone.
In two of the presentations that were made, it was suggested, I believe, that you wouldn't use nuclear medicine approaches if there was a high Ki-67. Is that correct? And if so, why?
Well, I think if you look at our algorithm, it depends what it is. If it's a midgut with a high Ki-67, we would probably still, if they had failed out at biotherapy such as somatostatin had failed to hold the tumour, and they're intensely positive on somatostatin imaging or gallium-68 dotatate imaging, we would still probably use the radiopeptide therapy. The reason being is that in our experience, chemotherapy has about a 5% response rate in this tumour group, even with a high Ki-67, when a lot of toxicity, whilst we may only be able to offer a 70% success rate, but with lower toxicity. With the foregut tumours, they tend to, because I have to work with oncologists, they tend to give them chemotherapy first, and some do well and some don't. But there are patients that we've treated with foreguts who've had lots of chemotherapy, failed that, high Ki-67, who've done extremely well with radionuclide therapy. So the problem is it's not an absolute rule, but it doesn't mean to say that you can't be treated because you failed chemotherapy and your Ki-67 is high. That doesn't seem to be a problem. I don't know again what the experience is.
Thank you.
Right, thank you.
There's one problem with patients with high Ki-67 that I'm talking about patients with more than 30%, which we have as a relative limit. It's not an absolute limit. And they tend to recur rather quickly. They might respond, but they may also have a tendency for early recurrence.
However, you can always retreat them if they haven't got significant toxicity.
I'd like to add to that because we've done this in London to a limited extent, and we're unfortunately disappointed to see that the tumor recovered and progressed before the bone marrow did in the highly proliferative disease. So we're not treating that group of people with isotope therapy.
My question actually relates to this retreatment program. I saw in the graph that you showed, Eric, a little bit of the pattern that we see when a child with leukemia becomes resistant to the chemotherapy agents, in that you get a response the second time, but your remission time is a little shorter. And I wonder if what's happening is there's a population of cells that is developing that has fewer receptors, or if there is some kind of resistance developing.
Well, I have to remind you that in this case, we started to inject 4 times, 4 cycles. Then we gave another 2 cycles and another 2. This huge interval. So you are comparing 4 versus 2 intervals, cycles. So the dose is 800 versus 400. Then you might expect to see a difference in the time that you have a progression-free survival, because the dose is different. So perhaps Sandy may explain this effect, but in my view there is a dose relationship in this case. You see a partial response. The response is the same, but still the PFS is shorter. But it is shorter after a lower dose. Only 2 cycles.
And take that question.
And to be honest, so far we had not the guts to treat a patient 4 times, and when you see a partial response, to give another 4 cycles later on, because we have to see what is the toxicity profile when you inject patients more than 800 millicuries. And to be very honest, we were involved in this study with yttrium DOTA-TOC, together with Novartis, a phase 1-2 trial with dose escalation, and we learned a lot. And also, I have to say, the FDA learned a lot. The point is that if you talk to oncologists or pharmacologists, they are talking about MTD, the maximum tolerated dose. That is always with pharmaceuticals which are not radioactive. But we know in nuclear medicine that using radiation, there are thresholds for limits for the bone marrow. In this yttrium tox case, we were allowed to go up to a 23 gray dose to the kidneys. We were not talking, together with the FDA, about the bone marrow dose. So we treated patients with high doses, up to 900 millicuries, and especially in the cases where the patients were pre-treated with chemotherapy. What was the lesson? If patients have been pre-treated with chemo in the past, you will see a low uptake of this peptide in the kidneys. Harmful effect by chemo. The effect is that the tubular cells are not reabsorbing anymore the peptide. So we were allowed to give a dose of 23 gray to the kidney. Since there was no kidney uptake, we were injecting 900 millicuries in those patients with an approval by the FDA. And at the end, we learned that this dose resulted in very high bone marrow dose, inducing in such a patient leukemia. So we have to be very careful. And we know a lot here, we see in nuclear medicine using radioiodine, where the main target, the critical organ is the bone marrow, but not so the kidney. Here it is different. So therefore, I'm always saying we have to be very careful at this moment to use yttrium-90. That is, that we cannot go over a dose of about, let's say, 360 by heart, 360 millicuries, based on our data with Novartis in the Novartis trial. In the future, what we want is to give a patient her or his dose, the maximum dose, in order to get the best effect. And that can only be done after getting enough information after what we are doing at the moment, giving patients 6, 8, 10 cycles. Yeah. And to do dosimetry. And there's a lot of work, and for this very purpose, we will use one SPECT CT camera only for dosimetry in the near future. That is important.
I think I have to share with you some of the questions that were sent up from the room. There was a spate of question writing following Dr. McEwen's announcement of impending lutetium therapy in Edmonton. And I'll summarize a number of them by just this one, which asks, will you follow Rotterdam's protocol or will you follow the Swedish protocol? Will you be accepting patients for treatment who don't live in Alberta, elsewhere in North America? And finally, will you accept patients for follow-up who've previously had these treatments offshore?
Dr. Krenning is sitting next door to me, so I'll follow the Rotterdam protocol. We will obviously be guided by best practices, and I think you have heard best practices today. The MIBG program that we have established treats patients from Western Canada. We've had some patients from Eastern Canada and some patients from the United States. So we would regard ourselves as a national resource within the constraints of the bed times that we have. We would like to establish a national therapeutic network, and there will be some meetings held over the summer where I hope we will be able to establish that, and obviously we will hope that CNETs will help us develop the, if you like, political and societal arguments for developing that network. We are currently seeing about 30 to 40 new patients a year for MIBG therapy. that will obviously double or more than double when we move to the peptides. I think Dr. Krenning has brought up a really interesting point in how do we know what is the correct dose and how do we know? We built the MIBG protocol cautiously over many years. We also have a better understanding of the toxicity profile of iodine than we do of certainly of yttrium. Lutetium and iodine are, in terms of physics characteristics, very similar. The pharmaceutical part of it is a little bit different. So please keep your fingers crossed that I don't run into any regulatory hurdles, and we will slowly expand the program, and we would hope again that CNETs would agree to be the conduit by which we build the national program.
Thank you. And here's a question that several of you might like to take a crack at. The questioner is asking about the complexity of therapeutic choices. Is there a hierarchy of treatments so that one treatment doesn't preclude later treatment by another modality? If so, what is the order? Who would like to try that one on? Dr. Krenning?
Somebody who's prepared to talk. John.
I think that I probably need to talk to my oncologist, and also might be able to have an opinion on this. I think we understand that certain tumours, people want to try more conventional therapies first, particularly when less conventional therapies are not available. So I think the very nature is that the radionuclide therapies tend to be after other treatments may have failed, and I think that may actually be appropriate. It may be different in Europe, where we have much better access and therefore we're able to treat patients earlier in disease. Certainly it doesn't seem to be too much of a problem almost any other treatment for radionuclide therapy, though there is a higher incidence of bone marrow suppression in patients who receive quite high dose chemotherapy. The question the other way around may be more of a problem in the fact that patients who have had radionuclide therapy and then fail that, well, the problem is what chemotherapy would be available. And at the moment we're looking at drugs like sunitinib, and there doesn't seem to be too much of a problem with giving sunitinib after the isotopes, but it would be, I think, more difficult to give things like the very heavy treatments like streptozicin, 5-FU, and cisplatin, which is a standard regime, and I think there we will be a little bit careful. So I think that within a multidisciplinary team, probably if you want a sort of strategy, it would be biotherapy first for most patients, chemotherapy these are all, first of all, surgery if you can cure it, that's number one, but if you can't, biotherapy, possibly chemotherapy, then radionuclide therapy, but also in parallel, we would look at things like liver treatments and other forms of embolization treatments. So the problem is every patient is different. And I think the other really important thing is that because neuroendocrine tumor patients don't just live for 2 or 3 years like many cancer patients, but maybe 10 or 15 years, over your natural history of your disease, you may get different treatments done. And it may be that you might even return to an original treatment after many years. And part of this is because the nature of the disease changes a bit over time, and I think the important thing is to have a group of people that are aware of what's available, able to provide that, either at their local site or at a referral site, and continue to re-evaluate your disease to find out what they think is best. So there is a sort of hierarchy, but we can go back if necessary.
We have to make one correction, John. We cannot talk about GAP-NET in general with regard to chemotherapy. We have to make a distinction between carcinoids and the pancreatic forms. In the pancreatic tumors, indeed, chemo can be effective. That is not the case in the carcinoids. So if you are talking about which therapy first, of course, indeed, for the midgut, it is therapy if you can do a debulking. Next step would be, I would say, the cold octreotide, and then priority, if the octoscan or the PET scan is positive. And it can be different in the pancreatic forms. So we have to make the distinction. But still, I would favor, but it is my personal idea, for the pancreatic forms, first of all, the radiotherapy and then the chemo, because with the chemo, you will have a negative effect on the bone marrow reserve. And we need this for the radionuclide therapy. So I would favor, first of all, also for the pancreatic form surgery, if feasible, then the cold substance, the octreotide, the somatostatin, then PRT. So in fact, there is no difference.
Well, I would also make a few comments about that, and I think that in general, although of course there are several exceptions, in patients with midgut carcinoids, as I said, we often start with biotherapy, somatostatin analogs, alpha interferon. There are some exceptions where we start with PRT, for example, patients with a little bit higher Ki67, where we start with lutetium. In patients with pancreatic NETs, the situation is, as Eric and John said, different. We normally, in those patients, start with streptozotocin plus 5-FU if they have a low Ki67, and that does not preclude lutetium in the future. There are exceptions to this rule, of course. In some patients we start with lutetium, and then we may give streptozotocin plus 5-FU afterwards if the patient progresses. In some cases we also give temozolomide either before or after. So I would say that normally you can give lutetium after chemo. Of course, some chemo will compromise the bone marrow kidneys. Lutetium may also compromise bone marrow kidneys, but future chemo may be possible despite that.
I'd like to jump in here as a medical oncologist and give a slightly differing viewpoint, because I don't believe in a hierarchy of therapy. You know, most tumors have one big chance of being treated. The first time, about 50% of the patients can make it for second-line therapy, and very few can make it for third-line therapy for most tumors. Neuroendocrine tumors are different. Most people can be around and they live long enough that some can avail themselves of every form of therapy that's around and available. And therefore, we would utilize a decision process using a multidisciplinary team. What is the patient's particular situation? Is it regional disease? Is it metastatic disease? What combination of therapies, what sequence of therapies would we believe from our expertise would give the best chance? There isn't a hierarchy. It's an individual decision from our team.
Thank you very much. I think we'll take just the last question here, which needs a short answer. Dr. Koch, are the Canadian consensus guidelines available on the web or anywhere else?
Quick answer, in 1 month they will be. The Current Oncology Journal site.
Thank you very much, everyone. It's been a long day. Thanks for